Good day, everyone, and welcome to today's webinar on POLST. Before we get started, we'd like to review a few technical items to make sure that you can interact with us today. The Q&A button, if you can click on that, a window will appear where you can submit a question, and we'll try to take as many questions as possible at the end of today's webinar. Recording, yes, we are recording today's session. However, participant lines are muted, so there's no need to worry about the recording capturing your interactions. We'll provide access to the recording on NASHB's website for you and others to view and share the recording as well as the slides after today's event. Thank you for joining us today. My name is Wendy Fox-Grage, and I'm a project director here at NASHB. And I want to thank the John A. Hartford Foundation for their very generous support of and their guidance with NASHB's Palliative Care Resource Hub. Additionally, I want to thank Ronnie Snyder, Amy Berman, and Scott Bain, who are our fantastic project officers. Next slide. And we have got a dynamic, fantastic lineup of speakers today. Kicking it off for us today is Amy Berman, our Senior Program Officer at the John A. Hartford Foundation, with presentations to follow from Amy Vandenbroucke, who is the Executive Director of National POLST, followed by West Virginia State Delegate Danielle Walker, followed by Danielle Funk, Program Manager at the West Virginia Center for End-of-Life Care. And finally, last but not least, we have Cindy Munn, CEO of the Louisiana Healthcare Quality Forum. And then we'll conclude with Q&A from you, our audience. With that, I want to pass it on over to Amy Berman. Amy, take it away.
Thank you so much, Wendy. Hello, I'm Amy Berman, a Senior Program Officer with the John A. Hartford Foundation, a proud funder of both NASHB and National POLST, and today's sponsor of the webinar on end-of-life practices using POLST. POLST is a portable medical order that tells all healthcare providers during a medical emergency what you want and what you want to avoid. On behalf of the entire team at the John A. Hartford Foundation, I want to thank all of our presenters and everyone in the audience joining us today. Your interest in ensuring that end-of-life care focuses on what matters most is music to our ears. That's because the John A. Hartford Foundation is a national philanthropy based in New York City with a mission to improve the care of older adults. And we work in three main areas: creating age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. Today's session is part of a larger grant from the John A. Hartford Foundation that supports NASHB in convening and engaging state leaders to improve care for people who are seriously ill, including improving access to and the quality of palliative care services. We hope you will take advantage and spread the word about the other resources and tools that NASHB is producing with our support to help all states ensure better care for older adults and other individuals living with serious illness. We also proudly support National POLST through a grant initiative that is building public engagement and access to quality palliative and end-of-life care services. 7 national organizations, including National POLST, have come together to develop a messaging framework, messaging principles, and collaborate on the scaling of innovative programs. Together, they and we can all help people live well in the face of serious illness. I would also like to thank Hamy Tawarson, Kitty Purington, Wendy Fox-Grage, and Salam Tashal for their leadership on our serious illness care grant at NASHB, and a special thank you to Amy Vandenbroucke, who leads our grant at National POLST. Finally, I want to note that our foundation has many resources that we hope you will utilize to ensure that all care is age-friendly, supports family caregivers, and improves serious illness and end-of-life care. To get to know us better, please visit johnahartford.org and sign up for our e-news. We look forward to learning with you all today, and thank you and enjoy the webinar.
Thank you, Amy, and thank you to NASHP for inviting me to participate today. I'm going to provide an overview of POLST, what is going on nationally, what is going on at the state level, and before turning over the presentation to my colleagues in West Virginia and Louisiana. When you are looking at advanced care planning, there are three buckets. The standard of care, which doesn't require a document. This is what you get if you have an emergency, everything possible to attempt to save a life. The two other buckets are voluntary. The first is legal documents. No provider is needed. Individuals fill this out on their own about general treatment wishes and who they want to speak for them. And medical orders, such as POLST forms, do require providers to fill them out and sign off. Like most advanced care planning, there's no federal law about POLST. Some states have laws or regulations about POLST, but it's mostly national POLST, building on consensus among our state leaders that create standards for POLST forms and processes, as well as policy and guidance to support those standards. We invite all states to participate in national POLST, and 45 currently do so. But all states are working on POLST and have it available in some capacity. Even South Dakota, Mississippi, and Alaska are working on it. South Dakota and Mississippi have laws about POLST. Nationally, we use POLST as a term, portable medical order. You may know it as something else like POST, MOST, MOLST, or TPOP. POLST is intended for a very specific population, patients who are considered to be at risk for a life-threatening clinical event because they have a serious life-limiting medical condition, which may include advanced frailty. POLST exists because other advanced care plans do not meet the needs of these individuals. This link will take you to a one-page guidance document that provides examples of appropriate patients, medical conditions, and other considerations. POLST provides an effective process and tool for this population to have their treatment preferences elicited and documented. Most POLST forms look like this one. Section A asks whether the person wants to be resuscitated or have CPR attempted. Section B talks about the goals of care and transfer wishes. If a patient wants everything possible, including being in the ICU, they can choose full treatments. If they don't want to be in the ICU, but are okay being in the hospital, they can choose selective treatments, which specifically says to avoid the ICU. And if they just want to be made comfortable where they are, they can choose focused comfort treatments. Let me walk you through how these three different buckets for advanced care planning play out. With the standard of care or do not resuscitate order, the patient has an emergency and EMS is called. Everything is done in an attempt to save the life, so the patient will be transferred to the hospital and stabilized, possibly in an intensive care unit, on a ventilator or on a breathing machine. If appropriate, the do not resuscitate order will be honored, but if the patient has a pulse or is breathing, no other treatment wishes are known, and so this is the level of care provided. With an advanced directive, again, the patient has an emergency, EMS is called, and everything is done in an attempt to save their life, so the patient may again end up in the ICU. Once they are stabilized, then the healthcare team looks at the advanced directive, if one exists, and identifies the surrogate. Together, they use the general treatment wishes provided in the advanced directive to inform a plan of care, either a lower level of treatment or still in the ICU. If the patient were healthy prior to this emergency, this pathway gives the healthcare team a chance to diagnose the patient and figure out what their prognosis is, and then what treatment options may be appropriate. With POLST, however, the process changes. Assuming the patient is part of the intended population, they can have a very specific conversation about what going to the hospital means to them, what being in the ICU and on a ventilator will mean for their goals of care and their prognosis. So the POLST is more specific. It is a medical order telling EMS what to do. So with POLST, the patient has an emergency, EMS is called, they review the POLST form. If it says comfort-focused treatment, the patient will be treated where they are. They won't be transferred to the hospital unless the comfort cannot be managed where the patient is. But even if the patient does need to go to the hospital, staff there will be able to see the patient's goal is to get back to where they were. If the patient chose selective treatment, then they would go to the hospital, but not to the intensive care unit. If they chose full treatments, then they may end up there. So you can see how a POLST form can impact transfer to the hospital and initial treatment at the hospital. And once stabilized, the POLST should be reviewed in light of the current medical condition. While POLST is instructive during an emergency, it also supports patients across the care continuum and in many facilities. helping providers align treatment with goals of care, treatments that might not be covered by the POLST form. Prior to 2004, 6 states had started a POLST program. These leaders realized that to make POLST portable nationally, they needed to have objective measures supporting best practices to encourage new programs to have similar forms and programs, including things like keeping POLST voluntary and the intended population. In 2004, National POLST started to develop that consistency by establishing program and form standards, giving states interested in implementing a POLST program a structured approach to follow. Portability is important for POLST. Patients are coming into and out of states. Many POLST appropriate patients travel 3 to 6 months of the year from New York to Arizona or Florida. So we need to make programs as consistent as possible to make sure that POLST supports those patients. In other words, state leaders need to consider all patients, not just those in their state, when they are making laws and policies about POLST. There's a lot we can do, but it can be distilled to this: keeping it simple and consistent. We need to make POLST easier for patients to use if they want it, and for healthcare professionals to know how to have a conversation, to translate patient preferences into medical orders on the form, and honor a POLST when it is presented. We do this by encouraging consistency among POLST programs, and here's why. Cornelia is 71, and she's going to be traveling from Atlanta, Georgia, to stay with her daughter in Maryland for an unlimited period of time. Her Georgia primary care provider has confirmed she's appropriate for POLST and is filling one out for her before she travels because, as a smoker and given her other medical conditions, they agree being on a ventilator would not be good for her. She believes if she became ill, her daughter would take her to George Washington Hospital in DC, but it's also possible she might be treated in Virginia or Pennsylvania, depending on where they are. Cordelia is called to ask if her Georgia POLST form is enough. I hate giving this answer, but right now, 5 forms, including the Georgia form, is best. While all these states may recognize the form, they also say the best approach is to make sure that she has the one they educate about handy, so there is really no confusion. This is one reason we created the National POLST form. Released in September 2019, this is the product of almost 2 years of intense collaboration among all state POLST programs. I am excited about the possibilities it provides to honor patient treatment wishes nationally, improve POLST through stronger quality assurance and research activities, and educate about POLST nationally. 5 programs have adopted it, and 5 more are actively working to do so now. 2 have adapted it, meaning that they've taken the form but made changes required by state law. Similarly, we are starting to have POLST registries all over the place, and like POLST forms, states are developing them to work within their state, but we again need to make sure there's portability. For Cordelia, traveling from Georgia means that her electronic health record and registry there, if it exists, needs to be able to talk with the EHRs and registries or health information exchanges in Pennsylvania, Maryland, Virginia, and DC. They need to be able to talk the same language about POLST form data. This is why we are working with the Department of Health and Human Services, Office for the National Coordinator for Health Information, also called ONC, on a POLST Clinical Document Architecture, or CDA. A CDA is basically a standard language that allows systems to electronically share POLST form orders with each other, validating them. We are also working on 2 other standards for POLST, FHIR and Nemesis. I'll finish my part with some notes on where to find additional information. Our website has 2 sides to it. The patient side, you can tell at the top, and also the menu bar, we use a pink. And on the professional side, which has a lot more information, you can tell at the top, or again, the menu bar uses aqua. You can find our policies at polst.org/policies. Our appropriate POLST use policy is the most important one to review. If you have any questions, please feel free to reach out to me. Thank you so much for your time, and I will now turn this over to Danielle.
Thank you for that, Amy. I'm going to go ahead and pull up my slides. Okay, so as Amy helped establish the reason that we have POLST and the benefits of it, I am going to speak specifically from the point of view of West Virginia. I am the program manager for the West Virginia Center for End of Life Care, which helps with all of the advanced care planning in our state. So to start with just a brief bit of history on our state specifically, the Healthcare Decisions Act was enacted in 2000, and then in 2002, my center was established and the amendment was added for the POST form specifically. As Amy previously mentioned, it's POLST nationally. In West Virginia, we go by POST. I will try to stick to the POLST language, but I probably will flip back and forth. So if you hear POST, P-O-S-T, it is just the West Virginia version. We will also talk about a registry in the bit, but as Amy mentioned, we were one of the 6 states that helped find the national POLST. That was in 2004. You've seen this graph a few times when Amy was speaking. I'm pulling this back up because we were the first state in the country to adapt that form. So as Amy has shown you, there is the national POLST form. The front page of the national form is on your left, and the front page of the West Virginia version of that form is on your right. We do not have the time for me to have you go through line by line on this, so I have written it down. The reason we adapted the form was because we think it's important to meet that national consensus for the best practice when it comes to portable medical orders, but we also needed to make sure that all of the things on our form were compliant with our Healthcare Decisions Act. So specifically, we removed the medical record number. We also removed the authority line on the bottom of it and the supervising physician signature. That is different than the healthcare provider who is completing the form. So our STELS has that. We also added a line in one of the boxes that allows you to specify a specific timeline for medically assisted nutrition. The 2 things that are really unique to West Virginia's form are the authorization box, which is more clearly defined as to what would happen if the patient lost decision-making ability and their healthcare status deteriorated. We also have an opt-in box because our registry uses an opt-in based system. So these are showing you on the left the things that we took out, and on the right, the things that we added. The content and the integrity of the form remains. We just tailored it to our specific needs. On the back, we changed a little bit more, with the majority of it being in those form and instructions section. In West Virginia, the back of the form is not required for the orders to be followed, but it is always encouraged because there is a lot of information there. Specifically, anywhere that it said legal representative, we just swapped that language out for medical power of attorney representative or surrogate. We also removed a lot of the information that did not directly relate to that medical power of attorney representative or healthcare surrogate, and any language that did not comply with the Healthcare Decisions Act. What we did add was more specific written out instructions on what to do if the form is reviewed, it's canceled, and a new one is not completed. We also added a bunch of information about accessing the registry, submitting forms to the registry, and searching the registry for patient forms. So again, pink on the left is what we took out, pink on the right is what we added. So our registry was created in 2010 and launched officially in 2012. And the whole purpose of our registry is to serve as the single source of truth for the state. We provide all of these patient forms, POST orders nationally, but also advanced care planning forms across the board. Anything a patient wants is there. It is available 24/7 for treating healthcare providers through the West Virginia Health Information Network, which is our largest health information exchange. Currently, our registry is the most comprehensive in the nation of its kind due to the number and types of forms that we accept. And whenever forms are accepted, in order to make sure we can be that single source of truth, there is a long process that everything goes through to make sure that what we are providing to healthcare providers is accurate. This goes through multiple levels of data entry and verification, including 3 different individuals who enter and review each form as it happens. When we make it to the quality assurance process, we verify all of the healthcare providers' licenses to make sure that the individuals who sign these forms are authorized to do so in our state. We accept healthcare provider signatures from outside of West Virginia. We just have to make sure that they are currently licensed as an MDDO, APRN, or PA. We also compare the form and all of the form elements to that Healthcare Decisions Act. And then we look at what we've entered and what is on the form, and we have a Sherlock system that goes through to make sure that our error codes are correct. Finally, we run things against death records to make sure that we don't have forms always available for patients who have already passed away. The reason we do this is to make sure when we are providing forms, our healthcare providers are not getting the forms below. The next couple slides are forms that have been submitted to the registry but will not be released to healthcare providers for given reasons. These two, you cannot read them. They are not helpful. The next one, it was just the back of the post form. The one on the right, that was the entire fax that came through. It was just the beginning. On the left, it might look like it would be correct, but what this individual has done is whenever they reviewed the form and updated their preferences, instead of creating a new document, they crossed out the old choice and initialed it and marked a new choice. So if you take some time, you can see that they want CPR and full treatments, but we don't always know that healthcare providers will have enough time to look at that and decipher it. On the right, we have conflicting directives. And so it is contradictory according to our Healthcare Decisions Act and according to the national standards to want CPR with anything other than full treatment. So once these forms are submitted and completed, our healthcare providers can search them. Richard Radford is a fake patient. Do not worry, we are not breaching HIPAA right now. We used a random generator online to create this patient. So what healthcare providers will do is log into WIN using their secure credentials and two-factor authentication, type in the patient name, date of birth, and then a match will appear. They select that patient, and in the box on the bottom left of your screen, it says Advanced Directives and Medical Orders. That will show you what forms are available on the registry. You will select the form that you want. A window will pop up saying that they come from the registry and explaining how to contact us. And then you can hit Get Directives, and that form, an electronic copy, is immediately available. This helps because EMS is trained to search the registry whenever they are en route to see a patient. So instead of going out not knowing if someone is DNR status, beginning CPR, and then having to stop, they will know that before they get there. If you ever have questions about West Virginia, specifically with the post form or any advanced care planning needs, feel free to visit our website on the bottom left or call that 877 number. It is toll free, and I'll be more than happy to help with that. I'm going to go ahead and stop sharing, and I'm going to transfer it to the other Danielle, who is one of our delegates in West Virginia.
Thank you, Danielle. I appreciate each and every one of you bringing this to the forefront. I appreciate each and every one of the participants taking the time to get educated about end-of-life care. As Danielle spoke to you about the legislative part, I'm going to speak to you on a personal level. I'm a newly grieving mother of my son who died on June 19th, 2021. He died 5 days before his 24th birthday. A nursing student who on his deathbed, the Friday, he died the Saturday morning, was told by his classmates and his instructors that he passed the course. When we think about end-of-life care, we usually think about hospice. The first time I heard the words living will and advance directive is when I became an employee of Dotrieve Hospital in Louisiana in 1998. My son was 1 year old at that time. It was a rush through of registering patients to vote, and I became intrigued in 1998. I soon began to bring information and education to my family members. It is very important to take this time with your family, with your healthcare provider, with the patient, with the caregivers, and have the understanding and know that your wishes will be granted. Dimitri got to the point of the living will in his advance directive. But unfortunately, after his second hospital stay, we didn't get to the point of filling out and having his physician have the medical order, the POLST, in the state of West Virginia. I remember the social worker coming to his room so we could get the forms notarized. What seemed like a process of just dotting the I's and crossing the T's. Little would I know the next week that we would be following that advance directive. Little did I know the Friday morning, his physician team would come to me and say, "Mom, there's nothing else we can do. We will not stop care. We will keep him on the ventilator. He will continue to get blood products. Do you want us to do CPR if he stops breathing?" Immediately I said no, and my mother said yes. That was the hardest decision a mother could ever make. I knew that my child had internal bleeding. I knew that he was urinating blood. I knew that we were suctioning the blood from his lungs. So what would chest compressions do to my baby? As Amy spoke about the different levels of end-of-life care, I turned off my camera because pain and paperwork is real. But with that pain comes progress and power. I am so excited that my son's wishes was followed. I am so empowered that we are having these conversations to bring more education and more love and more understanding and more awareness to the state health policies. I am thankful that whether you live in the state of Maryland, if you have services in the state of West Virginia, that medical order can be followed. What we did not get when we completed that advance directive is because of Dimitri's diagnosis, he could not become an organ donor. But with his advance directive, he was very thorough and he still donated his body to science. With us fighting for the diagnosis in the hospital and trying to find current medical treatment, it went over my head that I needed to complete the forms to donate my son's body to science. And it's not a guarantee that those bodies will be taken. Dimitri died on a Saturday. The Sunday we had his memorial. because he had friends coming in from out of state. Despite it all, from the first time we entered the hospital on May 19th and receiving the diagnosis on May 21st, the hardest call I received was from the folks who was going to take my child's body, telling me that I needed to complete the form that day and they would have to give the body back to us. Pain and paperwork. I am so thankful for national organizations, and I am so thankful for the West Virginia End of Life Care Center. Take a little bit of time to make sure that you are honoring the life and the legacies of your loved ones. Take a little bit of time that you don't have to second guess or question the unconditional love you have for a loved one. Take a little bit of time. If your state is not where it needs to be with POLST, that you call me. I will speak to your state representatives. I will attend whatever meetings and I will travel. This is human decency. This is a part of our life cycle. This is the exhale that every mother, father, loved one, spouse needs in that minute, in that second, that a last breath is taken. As something may be taken from you, what each of us can give is the respect to those final wishes. What it will lead to is some uncomfortable conversations for a movement of establishing a primary health care physician, making sure that an EMS driver doesn't have to ask those hard questions once they approach your door. I appreciate each and every panelist that has participated. I thank you for allowing me of keeping my son's legacy and life alive. He will forevermore be Nurse Dimitri Mack Walker to us. Remember, we never stop loving them. We never stop hearing them. And we will always honor them. I will now pass it on to Cindy Munn. Thank you.
Thank you, Delegate Walker. Me and Wendy and Slum asked me to talk about how did the POLST program get started in Louisiana? And what are some of the challenges that we faced early on? And what are some of the challenges that we're currently facing? So just to give you a brief background, clinicians started to express an interest in early 2000s about how to improve care for those with serious illness. And then in 2005, Hurricanes Katrina and Rita upended the healthcare delivery system, especially along the Gulf Coast of Louisiana, Mississippi. And the governor at that time and the legislature decided to commission healthcare redesign collaborative, which looked at multiple facets of healthcare and the delivery system in Louisiana, and wanted this group, which was consisted of leaders from across the state, business and healthcare leaders, and consumers, to make recommendations on how to improve how healthcare is delivered, and looking at evidence-based practice, what's the best model, and using that as a guide or a blueprint to implement in the rest of the state and potentially for the country. And Secretary Leavitt at the time, Secretary of HHS, participated and was very involved in this. There was one work group that was strictly focused on end of life. And the chair of that work group, who is our clinical champion today, came back to the full redesign collaborative and said they focused on last 2 years of life. They looked at who the serious illness population, what was happening, and then they reviewed literature on the POLST programs that were already in place, specifically Oregon, Washington, and New York. And working with the National POLST Office, the group recommended that Louisiana develop a POLST program. So the first thing this group did was go to the Louisiana State Medical Society and to seek their endorsement. It was futile to go and try to get legislation passed if you did not have the medical society support. So they were very methodical in how they approached this. So with the medical society's support, this healthcare redesign collaborative work group, they call themselves LaPost Coalition, educated legislators. They found a champion legislator to sponsor this. And they worked tirelessly to educate legislators on what this was and why it was so important. And legislation was eventually passed. We'll get into that a little bit later. But once it was passed, the coalition realized that this was just the beginning. The program needed to be administered by a group who would continue to stay focused on that. And that's where the Louisiana Healthcare Quality Forum comes into place here, is that we administer the program. We focused on, once it was passed, the implementation, education of stakeholders, and most recently, we launched LaPost Electronic Registry. Next slide. So just to give a little history on the legislation, the Louisiana Department of Health, initially when this was recommended that we form a POLST program, was unwilling to craft rules without legislative support for immunity. And at that time, there was concern this would be a glide path to euthanasia. It also required that we get approval from the Louisiana Conference of Catholic Bishops and the Family Forum. We had to educate them that this was not, we're not talking death panels. So in 2010, the legislation was passed, but the only way it would pass is if the document was embedded in the statute, something we would never recommend. In 2011, we started the education process with the initial focus on physicians, healthcare professionals such as nursing homes, assisted living, EMS, wanting to make sure that they were aware of LaPost and the importance of LaPost. And then we focused on the general population. We developed a robust website, again, with the educational tools, everything you would need, and a specific session on religious and cultural heritage so that providers could review that as a resource if they needed that. In 2016, we revised the document to its current state, and so that it follows, more closely follows the National POLST form. Next slide. So our challenge is that the document is embedded in the statute. And just like in 2016, we know we're going to have to periodically update it to incorporate new research and improve practices. The challenge is every time this comes up, we have to go back to the legislature and make sure, reach out to coalition members and groups that worked on the initial legislation to gauge how they would respond. We're always very cautious about that because there is potential risk to the current legislation where we could lose everything. So our goal, while we have a very, very good sponsor in the Senate, who, however, is term limited, our goal is to try to go back, get the document out of the statute so that and or adopt a national POLST program. So that is where we stand now. And we are in the process of assessing the current environment to determine whether or not we could overcome the potential risk if we went back and asked to change the legislation. And for some people, taking the form out of the statute would be significant. So we know that's something we have to face. Next slide. So I appreciate your time. If you have any questions, my email address is here. And if you'd like to see our website, I've also included that for you here. Thank you.
Great. Well, thank you so much. I want to thank our fantastic panelists. And if anybody has a question, any of our folks listening in, please just either in the chat or the Q&A, let us know about that question. I've got one to kick us off, and that is, and this goes to all of our panelists. What has struck me is, you know, we've heard all about, you know, the West Virginia and Louisiana efforts. And then both of these are in Southern conservative states. And so can you talk a little bit about the funding and how you were able to get it for your POLST programs?
I can start.
Sure.
When I initially, the Quality Forum absorbed this particular program because we felt it was important to improve outcomes for the citizens of the residents of Louisiana. And in addition to that, it fell under the mission of improving healthcare and how healthcare is delivered. And so we started with the Quality Forum assuming that fiduciary responsibility. As we went on, we went and looked for foundations who were interested in supporting this, who felt like this was extremely important. And so we got grant funds. Then we also got this civil monetary penalty funds from long-term care. And that was extremely helpful for us to continue to educate, and not only for LaPost, but there's so much confusion about the difference between the living will, healthcare power of attorney, and LaPost. So, and then we had the registry. So those were our primary sources of funding. We're full circle with everything that's been going on. The forum is now still, we're back to, we are the fiduciary, we are putting the money in from our other programs to keep this going. But we are committed that this is a program that will continue.
And I'll just give the very short overview of West Virginia's. We were originally in the state budget and funded through that for both the advanced care planning side for education, the printing and distribution of the POLST form, and our registry. In 2015, we were removed from the state budget, and we are now funded by specifically Dr. Clay Marsh at WVU Health Sciences. So that's West Virginia University Health Science Center. So we are funded there, and we would love to get back into the state budget at some point. Obviously, there's more potential with the state budget than with a university funding, but we are very, very lucky to have the money we have. We also rely very heavily on donations from supporters.
And then Amy Vandenbroucke, is this pretty common of like some state funding maybe, or some philanthropy? What are you seeing in other states that are able to pull this off with funding?
That's a $1 million question there. I think all the states struggle with funding. There's a lot of creativity. I think civil monetary penalties has been one that a number of our states have found some success with. It really kind of depends where the program is housed as well. Some states are housed within the Department of Health and Human Services, or something akin to that. Others are their own 501c3. Others are with academic medical centers. And so part of that helps influence where the funding is coming from. But we do try to share where we are finding funds and finding ways to collaborate with each other. So it can be multi-state projects rather than just everybody working individually. And I think even nationally, that's one of the things we're trying to promote with the forum and some of our activities is how do we get information that doesn't apply just to one state, but that will actually work in a number of states. Yeah.
And then another question I have is Cindy gave us a very good lesson learned for the other state officials who are listening to this call, which is don't embed your POLST document into the actual legislation, right? If you all could talk from West Virginia about maybe some lessons learned, and Amy is the two Amy's as well, kind of lessons learned, like so that other states who are listening in can not repeat any mistakes, right?
I will jump in on that. So when I mentioned that POST is in our specific Healthcare Decisions Act, our form is not in there. So POST as the concept, the definition, the purpose, that is in the Healthcare Decisions Act. It explains that it's a portable medical order. It explains who can complete it, as in the medical professionals who can sign it, but the form itself is not in there. And I think that is a huge benefit, which I know that Amy V is going to echo as well. It's not always easy getting things changed that are already in law. As Delegate Walker knows firsthand, there's a lot of discussion that happens. So I always recommend getting some fundamentals that will help protect the form and the reciprocity of the form. We are trying to work on getting it actually written in the code right now for reciprocity of other state forms, but I would recommend not having the form itself in the code.
So, and then I want to add something.
Sure.
We are, as Danielle was saying this, it's not all doom and gloom. We felt like, to get the legislation passed, there were compromises. So we got the form in, we were starting the conversation, which was our biggest thing. We also felt that as we moved this forward and showed the naysayers that this was not related to a death panel issue or euthanasia, that with time and how the form was being used and the education, that it would give us a little bit more leverage when we would go back. Not to say we don't have concerns, but that was, it was, do we just walk away or do we embed it? We just held our nose and we embedded it. And we felt like that was the best way to go. But it also gave us time to prove ourselves.
And then Delegate Walker, you're a legislative champion for this, and we have other champions are on the line. Can you talk to what some state opportunities are where we can really promote POLST?
I think we need to work with our local Department of Health and Human Resources. I think we need to lean on organizations such as AARP. We need to make sure when we are speaking about these things, we have healthcare professionals with us, and we have those personal stories to attach to this. This is healthcare. This is healthy healthcare. End of life care should not be a taboo. It is the liberty and the freedoms unhindered for what these patients want, need, and desire.
Great, thank you for that. And then I know in the chat, there's been some questions around when the POLST form is most applicable. And I know there's been some response, but I just thought we should have a little discussion around that. Danielle or Amy, do you want to address that at all?
Yeah, I touched on it a little bit on it in the presentation I gave. POLST is really intended for people that can have a very specific conversation, because this is a medical order that's going to be followed during an emergency. There needs to be there's not time to ask questions with EMS. So the person really needs to understand, what does CPR mean? What does it mean to be in the ICU? What does it mean to, be on a ventilator? And if you have a medical condition, this is where you can have that specific conversation. If you're healthy, presumably you want CPR attempted and you want full treatment. You want the time to understand, why did you have that emergency? What is the medical condition that you're facing? And be able to have a thoughtful conversation then about that. And then maybe a POLST is appropriate. But if you're healthy, our standard of care is to do everything possible. And you don't need a POLST form to fill that out. I think the only exception would be if you're looking at somebody with advanced frailty. Some states don't educate very much that POLST forms are intended for that population as well. So someone might be healthy, but for that advanced frailty, and there might be questions whether or not they do want CPR. And if they want to make an informed decision, they might want a POLST to be very clear, even though, I'm 90 years old, I know that I want CPR. But that's really a conversation then to have with your healthcare professional. In general, healthy people don't need it. They need an advance directive. They need to identify their surrogate, and they need to have a conversation with their surrogate about what they would generally want.
Just to add to that, because everything Amy V just said was absolutely correct, I am just going to pull on one little thing that she said about emergencies and why and how POLST can be helpful with this. Just for West Virginia, the current numbers that we have are that EMS providers, so ambulance is called, from the moment the ambulance arrives until those EMS providers start giving whatever treatment, whether it's CPR or just comfort measures, it's 8 seconds. There's 8 seconds for them to figure out what's going on. So definitely, like Amy said, POLST form isn't necessarily for everyone, but it is something that I encourage everybody to start that advanced care plan in general sooner, rather than trying to figure out what somebody wants in those 8 seconds, because you're not going to achieve it then.
Then can you all talk a little bit about outreach? I know Delegate Walker encouraged all of us to have these conversations in our own lives, but can you talk about in West Virginia and Louisiana, outreach efforts and take-up rates, the numbers of people who do have POLST, and kind of where we need to get to?
So with West Virginia, I actually love doing presentations like this. It's one of my favorite things to do. So when I first came back to run the center, I pretty much marketed myself to anywhere, everywhere I could. And so we do a lot of education presentations to the general public through senior centers, through Osher Lifelong Learning Institute, HR departments for employees. We also give education specifically to providers. Basically, our outreach to the general public, it goes with whatever the public's doing at that time. We did a really awesome National Healthcare Decisions Day virtual event because of COVID, and Delegate Walker helped with that, and it was awesome. And we do have a lot of individuals that are using the POST form. I don't have the current registry numbers off the top of my head, but I can say that when we adapted that national form, when we rolled that out, as Amy knew, because I sent her an email that went, whoa, I didn't expect this. We ended up sending out over 15,000 POST forms in that initial time, which is way more than we normally do, just because so many healthcare providers were excited about the form.
So for Louisiana, we looked at, for the providers in particular, we looked at the hospice and palliative care organizations to get the word out, the Hospital Association, State Medical Society. So we looked at the professional organizations that to providers were the trusted organizations that we could get this message out. For the consumers, we looked to AARP, because they are very trusted. But then, you know, this is not a topic that people want to discuss. It is a tough topic. So we turned to the churches, the faith-based organizations, to get feedback on how best to communicate to their members. And that was extremely helpful in that, you know, initially, if we were welcome in the church to provide information, we had our foot in the door, at least we were getting information out to people. And they had the opportunity to ask questions. So we have been doing this for 11 years now, and it's going to be never ending. And the biggest challenge is many people do not want to have this type of conversation until they're faced with it. And that's, you know, it's stressful for everyone.
Well, I cannot thank you all enough. I can't thank you enough for the work, the important work that you're doing. And thank you so much for joining us on our webinar today. As a reminder to people on the webinar, please fill out the survey at the end of our webinar, and we greatly appreciate your feedback. With that, thank you to our fantastic panel of speakers, and thank you all for joining us today. We'll make sure to post the recording and the slides from this webinar to the NASHB website. With that, many thanks.